hoping that you can all see the title slide.
Yeah.
So as Luke said, I'm a professor of respiratory medicine in Nottingham. I run the UK LAM Centre. I'm a medical advisor to LAM Action in the UK, and I'm also been a professional advisor at the TSA for a good while now. So tonight I was going to speak probably for half an hour or so about just what LAM is, how LAM affects people with tuberous sclerosis, what symptoms and problems it can cause, a little bit on treatments. And then Luke and Anna had asked me, particularly because there've been a lot of questions in the patient forums recently about women's health and LAM, and particularly a couple of things I was going to talk about were really pregnancy and a little bit on menopause. And of course, the last bit of the session will be people to ask questions. So the first thing, why does LAM have such a long real name? So the lymphangioleiomyomatosis bit really is just the little different elements of the disease grouped together. So LAM affects the lymphatics, which is the lymph thing, but also not only lymphatic vessels, but blood vessels, and that's the angio part. And these little vessels and the lungs themselves are invaded by these slightly abnormal cell types called LAM cells, and they look like smooth muscle cells, and that's what leiomyo means. And mitosis is just a disease. So lymphangioleiomyomatosis really is sort of based upon the pathological features, really. There's two other bits of terminology that you need to understand. LAM occurs in two contexts, obviously in people with tuberous sclerosis as adults, but it also occurs on its own, and that's called sporadic LAM. Most of the patients I look after tend to have sporadic LAM, and there's a little bit for reasons that aren't really clear, because TSC LAM is probably more common in reality. Most of the research I'm going to talk about has been done on sporadic LAM with some people with tuberous sclerosis incorporated. So LAM, as I said, is an emerging problem in tuberous sclerosis. It's unusual as it almost only affects women. Occasionally men can get features of LAM, but it tends not to cause problems in men. So most of the things I'm going to talk about are really relevant to women with tuberous sclerosis. So LAM is relatively common in adult women with tuberous sclerosis. It doesn't really happen in children. If you look hard by doing a lung scan in everybody with tuberous sclerosis, if you look at all the women with TS when they're 20, about 1 in 10 of them will have signs of LAM, and I'll show you what that looks like in a moment. As time goes by, LAM becomes more common, and 60, and in one small study, 80% of women with tuberous sclerosis had some evidence of LAM by the age of 40 years. Now, most of these people that we picked up by looking with CT scans had very mild disease and didn't have symptoms. And perhaps one of the main things to take away from tonight's session is that LAM is very variable, and many people with tuberous sclerosis don't have symptoms. But for some people, the disease can progress rapidly and cause a number of problems, which we're going to talk through this evening. But I don't want people to think just because they've got a little evidence of some LAM on their scan that necessarily these things are going to happen to them, because as I'll stress later, you need to talk about your health with your doctor one-to-one, and not just take everything from talks and internet articles. So, as I've said, LAM is a very female-specific manifestation of tuberous sclerosis, and we think this is because LAM cells are affected by the female hormone estrogen. So estrogen is a hormone that rises in the middle of the menstrual cycle, it goes up in pregnancy, and it falls after the menopause. If you put estrogen on LAM cells in the laboratory, they grow more quickly and they move around in model systems much more quickly, and they sort of cause more trouble, really. So we think estrogen is probably bad for women with LAM. So we recommend that women with LAM avoid any medicines with estrogen in them, and that's either the combined contraceptive pill for women before the menopause and hormone replacement for women after the menopause. The other thing about estrogen and LAM is that as it goes up during pregnancy, often pregnancy in LAM can be complicated, and I'm going to talk about that a little bit. The good news is that when you get to the menopause and your natural estrogen falls, the rate of progression of LAM tends to slow down. And that's been shown in lots of groups of women, mostly with sporadic LAM, but the disease is pretty much the same in tuberous sclerosis. So in people with tuberous sclerosis, LAM gets diagnosed through one of two routes, really. Either people have lung symptoms and they get investigated and LAM gets diagnosed, or increasingly now, people get, LAM gets discovered when people are screened for it at the age of 18. So the document that you can see on the screen are the international guidelines that we set for how you look after people with tuberous sclerosis. And one of the big changes in this document was that we recommended that at the age of 18, women with LAM, women with tuberous sclerosis had a CT scan to see if they had LAM. We also recommend that people have lung function tests from time to time. In the old days, LAM only got discovered with lung symptoms, and to some degree still does now, because lots of people have missed the screening scans because they've only recently been brought in. And the common way that LAM comes to medical attention is that either people develop breathlessness gradually over a number of years. Sometimes that gets diagnosed as other things like asthma. But in some cases, the LAM gets diagnosed when someone's lung collapses. And I'm going to show you some lung cysts in the lungs of people with LAM, and these cysts can sometimes leak air out and the lung can collapse down. That causes breathlessness and chest pain. Person usually ends up going to A&E, and then LAM can get diagnosed from there. So whether you get screened or whether you come to medical attention because you've got breathlessness, usually the penny drops that you have LAM when you have a CT scan. So I guess a lot of people have probably had CT scans, maybe of their brain or their kidneys, or their lungs also, and you probably know the little cartoon on the left of the picture here is of someone going into a CT scanner. So the scanner's right around the person and they're lying on a table. And the main picture here is a CT scan of someone's chest. So the bottom of the picture is the table that they're lying on. And the area I've highlighted here that says spine, that's the backbone at the back of you. The heart's at the front of your chest or the top of the picture. And just off the top of the screen here would be the skin on your front. So the lungs are these big dark grey areas. Chest doctors, well, actually most doctors always look at x-rays the wrong way round. So on the left of the picture is the right lung, and on the right, the left lung. The grey colour that you can see is what the lung normally looks like. The little white things are blood vessels. The thing that tells you that this person has LAM are the black circles with the little very faint white edges. And some of those are highlighted with the yellow arrows. So this person has relatively mild LAM. They've got a number of cysts in their lungs. Their lung function's normal. And this would be what somebody's lungs would look like when they had a screening CT scan. As the disease gets worse, the the cysts become more numerous and replace more of the lung tissue and cause the problems. So if you have a CT scan when you're 18 and you don't have LAM on your scan, that's a good thing, but it doesn't mean it will never appear. We know that LAM gets increasingly common as people get older, going up to sort of maybe somewhere around half of women with tuberous sclerosis by the time they're 40. It's also a little bit more likely if you're going to have LAM or you're going to develop LAM if you have a TSC2 mutation compared with a TSC1 mutation. Much less likely to have LAM in TSC1, and if you do, it's often a bit milder. So if you don't have LAM, when you go and see your tuberous sclerosis doctors, they will probably ask you about LAM symptoms, and mostly these are shortness of breath, really, each time you go to. And if you're developing shortness of breath, they might want to do further investigations, either another scan or perhaps some breathing tests at that point. And these two sets of guidelines here, both the international one and the UK one that we did recently, recommend that that you have a CT scan every 5 to maybe 10 years to see if LAM has developed. If you don't have LAM, we recommend that you still take the same precautions about avoiding estrogens, such as in the contraceptive pill, in case that helps LAM develop as time goes by. And we also recommend that you look after your lung health generally by not smoking. If you do have LAM, then the next thing we do usually is get some breathing tests. Now, the lungs are a system for moving air in and out of the alveoli, where oxygen is taken from the air and goes into the bloodstream, and carbon dioxide, the waste product, is taken out of the body. LAM can affect both the airways and the alveoli, and we do different types of tests, but basically, and I guess some of you may know, have had this done, you have breathing tests, which involves breathing in and out of a number of different machines, like the picture at the bottom of the screen here. And we do different tests to measure your airway function and how efficiently you get the oxygen into your bloodstream. We also very often measure your oxygen saturations. These little fingertip probes that used to be sort of a high-tech bit of equipment, but now you can buy them in sort of Asda and places. It can be used to measure people's oxygen saturations, and this is dependent on how good their lungs are. And what we often see in people with LAM is that they have reasonable resting levels of oxygen, which are the little circles on this chart here. And the green area and the white area are reasonably acceptable levels of oxygen. But if you have significant LAM, when you exert yourself, particularly so if you walk briskly, as we've asked these people to do, you can see some of these lines drop down into this other area where the saturations are lower. So we might often get somebody measure your saturations when you're resting, and then walk you around the clinic area and see if your oxygen levels falls. And that's another helpful assessment of how significant your lung disease is. So if you have LAM, the way to work out how bad your own particular disease is, and as I said, there's a huge range from really not affected by LAM at all to it being a more significant illness. We look at your lung function tests. We look at how many of the little cysts you have on your CT scan, and we see what your oxygen level does when you walk or take exercise. And then we factor in how old you are, what other medical problems you've had, whether you've had pneumothorax or other problems, and other factors to do with your tuberous sclerosis. And then we can make an overall estimate of how bad your LAM is. And I would suggest that every woman with tuberous sclerosis who has LAM, somebody should sit down and look at all these factors before they're planning your care. So I'm going to talk a little bit about LAM-related problems now. so perhaps the most dramatic thing that happens to people with LAM is they have a pneumothorax or a collapsed lung. So the X-ray on the right is a chest X-ray of somebody with LAM. And the left lung's fully inflated. The side of the chest that says left lung has this hazy appearance, and that's the lung in it. If you look on the at the right lung, you can see where the big white arrow is, that there's no hazy appearance there, and that's because the lungs collapsed down, and it's now collapsed right down to the bottom to where this little bluey coloured arrow is. And once that happens, usually that causes chest pain. You might feel breathless. Usually it's a sort of sudden thing, or you wake up with it. You usually can tell something has happened. And the treatment for this is to try and remove the air from this space between the lung and the chest wall. I don't know if you can see my cursor, but on this little cartoon on the left of the picture, a tube has been inserted into the pleural space. That's called the chest drain. That takes the air out. If the lung seals up and the air's gone, you can take the tube away. However, sometimes for people with LAM, pneumothorax can be difficult and doesn't settle down very easily. The air continues to leak out, and those people might need an operation to fix the hole in the lung and stick the lung back to the chest wall. And that's a helpful treatment to A, fix pneumothorax, and B, prevent them from happening again. This chest X-ray, the arrow at the bottom of the left lung here shows this sort of white hazy patch. And this is called a chylous effusion. So this happens to women with LAM when their lymphatics get blocked. The lymphatics are little channels that run next to blood vessels. Usually you don't know they're there. They absorb the tissue from the fluid from the tissues in your skin, and they also absorb fat from your food. And usually they just sort of mind their own business. In LAM, they can get blocked, and they can cause the fluid that's in them to leak out around the lung, and this can squash the lung down. You can also get this happening in the abdomen, and the fluid can build up there. And if this happens, in the old days, we used to drain this out, like with the chest drain, a bit like we've just talked about for pneumothorax, but actually now we use drugs like sirolimus or everolimus to treat these effusions. This CT scan is a picture of an enlarged lymphatic. A small number of people with LAM will have enlargement of the lymphatics in their abdomen and pelvis, and the white arrow here is pointing to an enlarged lymphatic. The bluey coloured arrow is the bladder. So this is right down in the pelvis of a person with LAM. These are called lymphangioleiomyomas. Usually you don't know they're there, but occasionally they can cause symptoms like bloating. So on the whole, LAM can cause a range of symptoms. There may be none at all. And actually, for a lot of people with tuberous sclerosis and mild LAM, there are no symptoms. If the LAM gets more significant, there may be breathlessness, and this is usually when you're doing something. Not many people are breathless when they're resting, but might be walking up hills or stairs. Sometimes people can get airway narrowing and get wheezy, make a sort of musical noise when they breathe. Pneumothorax can cause chest pain. And if you get chest pain due to pneumothorax, you should have an X-ray that same day just to make sure that, just to see if it is in fact a pneumothorax. Sometimes people cough, and sometimes people cough up little spots of blood. It's not usually a lot, but that can sometimes happen. It's worrying. It doesn't mean that there's cancer or anything, but it's a feature of LAM sometimes. Some people cough up the milky chylous fluid. And as I've said, some people get abdominal bloating or swelling if they have the lymphatic changes in their abdomen. Quite a common symptom for people with LAM and people with tuberous sclerosis to some degree generally is fatigue. And so people might feel more tired than they would expect, particularly when they have LAM. So once you have LAM, as time goes by, some people will develop more cysts, sometimes some people won't. If there are lots of cysts, then the cysts can reduce people's lung function and make them more breathless as time goes by. What this graph is here, each one of these lines is a person with LAM. Some of them have tuberous sclerosis, some of them have sporadic LAM. And this is a lung function test called FEV1. This is an important test for people with LAM. It's a measure of airflow. And you can see that a lot of these lines gradually slope downwards. The lines on the right of the graph that are labeled MTOR inhibitor, these are people who are on treatment with either sirolimus or everolimus, the MTOR inhibitors. And if you have LAM, this FEV1 measurement will fall by about 70 to 100 milliliters a year. Now, everybody's FEV1, even if they don't have a lung condition, falls after the age of 25, just because they get older, by about 20 mils a year. So if you have LAM, that's maybe 3 to 5 times as fast. The important thing to bear in mind is that this is really variable, sometimes doesn't fall very rapidly. But if somebody does have loss of lung function that's higher than normal, we can now offer them treatment with sirolimus or everolimus, and you can see here that the rate of FEV1 loss, it goes back to a very normal sort of level. That the average in these patients was 7 mils a year. Actually, it's a bit better than normal. So we have a treatment for LAM if it's progressive. So if you have LAM, we recommend that you get a regular medical review. And sometimes that's at the start of treatment, that's quite frequently, maybe every 3 months. But most of the people I look after, we see them once or maybe twice a year. And at those appointments, we ask about symptoms, we check their lung function, and in between times, if they have other things like chest infections or pneumothorax, then obviously we deal with those at the time. So LAM is a thing that most people live with. It can be progressive, but we have a treatment that can slow it down if it becomes a problem. So some people with LAM also benefit from the types of medicines that we use for asthma. So the graph at the top here shows that about 1/3 of patients with LAM, and it gets more if your LAM is worse, will benefit from the types of inhalers that we use for asthma. Nowadays, we tend to use a long-acting inhaler that you take once in the morning, and that helps with airflow, and people tend to feel less breathless when they're doing things when they use that. Obviously, the big news, but it's pretty old news for, I guess, everybody on this call now, of course, is that sirolimus and everolimus reduce decline in lung function. They also reduce the size of angiomyolipomas, they reduce the volume of SAGAs, they improve skin features, and of course they're being trialed for epilepsy and all sorts of things now. The graph at the bottom here is from the MILES trial that was originally done in the USA and Japan, showing that sirolimus in this case reduced, stopped the fall in lung function in patients with active LAM. Most of these people had sporadic LAM, but actually some had tuberous sclerosis. The other piece of good news about drug treatment is that there's an awful lot of research being done at the moment. And I would be quite surprised if within the next 10 years we didn't have treatments that we could add into MTOR inhibitors that would stop the disease much more effectively. And of course, we're looking for cures for LAM at the moment. And there is a lot of work going on in that space now. So there's good cause for optimism. So if you're sitting there thinking, should I be on treatment like sirolimus or everolimus for LAM? Again, we go back to this overall assessment, looking at your lung function and your age and your other symptoms. if you develop LAM at a younger age, we would be more likely to treat you with an mTOR inhibitor than if you developed LAM when you were older, perhaps around the time of the menopause, when we knew that it would be less likely to progress. So this is an individualized decision. And if you just have a small number of lung cysts and no symptoms, there probably isn't a benefit from being on LAM just for this, being on an mTOR inhibitor just for LAM. Of course, lots of people are with tuberous sclerosis on mTOR inhibitors because they have angiomyolipomas or they have SAGAs or other issues. And if you're on one of these, that'll be protecting your lungs, even if you have very mild disease or, in fact, don't have LAM at all. So those are the treatments, really. In terms of what people can do themselves, well, it's helpful to know what the signs of a pneumothorax are, the sudden onset of chest pain and breathlessness, and what to do in that situation, which is really go to A&E that day and get an X-ray to see if you really had a pneumothorax, because obviously there's lots of other causes of chest pain that are not serious. You should treat chest infections promptly. You should keep up to date with your vaccinations for the flu, pneumonia, and coronavirus, of course. I'm going to talk a little bit about pregnancy in a minute. It's very important when you have a lung condition, and in fact, for everyone really, to keep as fit and active as they can. If your muscles work efficiently, if your heart's used to responding to exercise, then your lungs don't have to work so hard to do your normal day-to-day things. And basically, if you get a bit fitter and you don't put on extra weight, you will be able to do more with the lung function that you have. And there's a thing called pulmonary rehabilitation, which is an exercise program for people with lung disease that works in lots of lung conditions, actually, which is aimed at really getting fitter. But it also works for LAM now. So most younger people with LAM tend to do their own thing and go to the gym and go to exercise classes or dance classes or whatever it is to keep active, or do sports. Older people sometimes who've lost fitness benefit particularly from pulmonary rehabilitation. And of course, I don't have to tell you that support groups, because you're all at one at the moment, are a useful source of information on these things. If you have LAM, we suggest that you avoid estrogen in a contraceptive pill and hormone replacement. And as I said, we discourage everyone from smoking. I'm a chest doctor. I can't stop telling people not to smoke. So I'm going to talk a little bit about pregnancy now. As I've said already, LAM's an estrogen-driven disease, and estrogen goes up during pregnancy. For a long time, pregnancy has been a big issue for women with LAM. Often the disease starts around about the time they're thinking about having a family. And in the olden days, people just got told that it was too dangerous to have children, and that message is still out there somewhere. But pregnancy, if you have LAM, and this includes TSC LAM, does increase your risk of having LAM-related complications. So this table here, I apologize, there's rather a lot of information on it, but it's just really to highlight a study that we did recently looking at 16 people with LAM. 2 of them had TSC and LAM, looking at the outcome of pregnancy. Now I'm showing you this study because we had lung function tests before they got pregnant, during their pregnancy, and after their pregnancy. And what you'll see from this chart, or maybe I'll just highlight it. So we've got 16 patients here. 5 of these people had a pneumothorax, a collapsed lung during their pregnancy. These people, I think, all needed either one of those chest drains, and some of them needed operations because both lungs collapsed during pregnancy. And in a bigger study of pregnancy, the risk of pneumothorax during pregnancy, you are more likely to have one than not. This is a treatable problem. The good news about pregnancy in LAM is that in all the patients that I've studied in research studies and have seen, all the babies came out fine. And so most people ended up with a healthy baby at the end of the time. Of course, if you have tuberous sclerosis, you also have to consider the genetic issues around pregnancy. And the final thing that you need to think about is that at the moment, we don't know whether sirolimus and everolimus are safe to take during pregnancy. So at the moment, everybody is recommended to stop this drug. So that does mean that if you're getting a benefit from those drugs, you will lose that during pregnancy. It might be that the drugs are safe. It's just that there's not much data at the moment. It's a bit of a watch this space thing. So these lines here are the 16 patients' lung function tests before pregnancy, which is to the left of the dotted line, and then after pregnancy, which is to the right. And I show you this graph just to show you that it's very variable. You can see the patient at the top here, the lung function goes up and down a bit, but it doesn't really fall before and after pregnancy. And this is true of some of the other ones. But 1 or 2 people lose lung function during pregnancy. Now, that might have happened anyway, but we do warn people that their disease may become more active when they're pregnant. So if I'm talking to someone with LAM who's thinking about becoming pregnant, I warn them that there's a risk of pneumothorax and that they may lose a bit of lung function. Usually these things are manageable. If you start off with good lung function, if you just lose a little bit, if the worst happens, then you're usually fine afterwards. If your lung function is lower, then clearly that's going to be more of a problem and you may be a bit more breathless afterwards. So again, it's something that you would want to talk about in detail with your LAM doctor when you are considering it. And it's an important decision. The final thing I was asked to talk about was about coronavirus and LAM. And it just happens that we just finished a study where we'd looked at the impact of coronavirus in people with LAM. These 2 people are Bruno Baldi and Nishant Gupta. Bruno is a LAM doctor in Brazil. Nishant is the scientific director of the LAM Foundation in the US. And the 3 of us phoned all the LAM doctors that we knew around the world and managed to collect 91 patients who had LAM who had had coronavirus. Now, that's not very many, but it was people who definitely had coronavirus. It's not, oh, I couldn't smell the coffee last week, so maybe I had COVID sort of thing. It was, they definitely had a positive PCR or another definitive test. So 17% of the 91 people had TSC LAM, the remainder had sporadic LAM, and you can see they came from different countries. Elżbieta Radzikowska in Poland, who you may know through the TSA, did very well in sending us patients. So the symptoms of coronavirus in people with LAM were the same as everybody else. Most people felt tired, they had a temperature, they coughed a lot, more than half lost their appetite. The level of the increase, there was more breathlessness in people with LAM than normal. But the other symptoms were actually pretty similar. So the important thing is, what was the outcome? Because the thing we were worried about originally is that we, as lung doctors, we know if you have emphysema or you have lung fibrosis and you get coronavirus, that's very bad news. You do worse than other people. And we were worried that that might be the case for people with LAM and TSC LAM. But actually, it wasn't really. About this little pie chart here, so a small number of people had no symptoms, The majority of people just felt a bit ropey, stayed at home, self-isolated, didn't take any particular treatment other than paracetamol, and got better in a couple of weeks. About a third of people ended up having to go to hospital, and those tended to be the people with a more severe LAM with a lower lung function. A couple of people actually were in hospital and then got coronavirus when they were there for other things, which wasn't good. Only one person died, and that lady had very low lung function, had LAM for a very long time, and had other complications of LAM, and was using oxygen continuously, and was really quite poorly. The remainder of the people all survived. A reasonable number of people, about a third of them, had symptoms for more than 6 weeks, or had long COVID or post-COVID syndrome. So mostly that was feeling more tired. Occasionally that was feeling more breathless. A small number of people also used their oxygen more, or needed oxygen when they hadn't done beforehand. So the outcomes from this were reasonable when you consider a lot of these patients had quite low lung function. The other thing that we were really interested in, and this is very important for people with tuberous sclerosis, is what about the effect of taking an MTOR inhibitor if you happen to be unlucky enough to catch COVID. So we compared the outcome of people with LAM who were taking either everolimus or sirolimus with people who weren't. The groups were quite similar. The people on the MTOR inhibitor had worse lung function, which is not surprising, as that's why we were treating them. But the number of coronavirus symptoms, how long they were in hospital, the incidence of long COVID, were all very similar, actually, between the people taking the MTOR inhibitors and not. The patient who sadly died was taking an MTOR inhibitor, but as I say, she did have very advanced disease. So I don't think the outcome of this study looks too bad for people with LAM and coronavirus. The outcomes aren't that different for other groups of patients, certainly better than other lung diseases. People who are most likely to end up in hospital with a more severe infections, excuse me, and did tend to have a lower lung function, especially this gas transfer test that we do. But mTOR inhibitors didn't really affect the severity of the disease. So I would suggest that people with TS generally, and also TSC LAM, continue to be careful with social distancing and hygiene measures, which actually is also helpful for others not getting other chest infections. But there's no reason for them to stop their mTOR inhibitors. But we're recommending everybody gets vaccinated, including having their booster vaccine. The only thing we suspect will happen is that sirolimus and everolimus may reduce antibody persistence, and so we're recommending a third vaccine for all of those people and a booster. So that's all I've got to say, really. Thanks very much for watching. I'll be free to take questions for a bit now. I'll just unshare my screen.
Perfect, great, thank you. Thank you, Simon. That was excellent. Very, very, very interesting. We managed to cover a lot in a short space of time, which is great. As Simon has said, please do either write in the chat box, or if you would like to ask a question verbally, either just put your hand up or pop yourself off mute and ask it. We'll go from there. I've got one or two questions that I've noted down myself actually during the talk. The first one is, Simon, should all women with TSC be monitored for LAM beyond the age of 18, whether they've been diagnosed or not?
Yeah. I mean, because LAM becomes more common as you're older, then it will appear after the age of 18. So we would recommend that people get asked about any respiratory symptoms, particularly breathlessness, when they go to their TS reviews. And the guidelines actually suggest repeating CT scans every 5 to 10 years. So just to sort of capture those people. In practical terms, we don't really want people worrying about getting another thing all the time. Mm-hmm. But we would normally recommend that the things people who have LAM do, like avoid the estrogen-containing contraceptive and things, probably sensible for all women with tuberous sclerosis. If that's not too difficult for them. Everybody's different, but that's the sort of general advice.
Yeah, absolutely. Thank you. Another question that I had as well, is there a connection between either having LAM or the severity of an individual's LAM based on the severity of how TSC affects them?
Not really. I mean, one of the difficult things about TSC is, how variable it is and the different constellations of symptoms. The two things that very much go together are LAM and angiomyolipoma. So most people with TSC LAM will have angiomyolipomas. Not everyone, but very commonly. And I mean, a lot of the patients I see at the LAM Centre have tuberous sclerosis, but haven't had a lot of the sort of what you'd say the classic tuberous sclerosis problems of epilepsy and sometimes learning difficulties and things. And some of them have been diagnosed with tuberous sclerosis, as an adult, quite unusually. In fact, I saw somebody last week actually who was diagnosed at 21 when she had a problem with an angiomyolipoma. And so it just is a very variable problem. But then, we see people with, unfortunately, all of the difficult features of tuberous sclerosis who also have LAM as an adult.
Yeah, great. Thank you. Thank you. That makes sense. If anyone does have questions, do please write them in, as I said.
Sorry, I just wanted to ask a question. My daughter is she has tuberous sclerosis. She's only actually 4 years old, and I joined this obviously for information for obviously future use. But she's so far come back as genetically negative. So they've done a few DNA tests now to have a look at her genetics, and she's negative for it. I was just wondering, does that have any correlation with whether she might get LAMs or not?
I think the prevalence of LAM in people with in whom we can't find a mutation is similar-ish to sort of patients with TSC2, really. Elizabeth Taylor in the US has just published on this. Actually, I think that's correct. So it doesn't, what I'm saying, it doesn't make a big difference, really. Fortunately, LAM is, may never be a problem for your daughter, and certainly won't be for a long time yet. Hopefully we'll have worked out a cure by the time she's old enough to have it.
Thank you. Yeah, I hope so too. Yeah, we're seeing as she's only 4. Hopefully there'll be a lot of advancements by then. But thank you ever so much for your answer.
Okay.
Thank you, Beth. Thank you. Now, Joe and Nicola and Harriet, I can see you've got your hands up there, so we'll go first with, I'm not sure who brought it up first, so I'm going to say we'll go with Joe first, and then we'll go with Nicola and Harriet afterwards.
Hi, thank you, Luke, and thank you, Professor Johnson. It's been very informative, because my daughter's actually 16, nearly 17 now. So we've just had the TS review in Alderhay in Liverpool, and they were saying in the transition, they will be scanning her lungs in the next sort of year and a half, because she does have AMLs and she is TSC2 diagnosis. So a couple of things that really I'm a bit confused about, which might be able to help me, is she has been struggling a lot with, she has a lot of AMLs on her kidneys and the liver and whatever is quite smattered, you know. So they're testing her at the moment for, they think there might be something on her pancreas because she's having stomach issues, lots of issues. She has lots of bloating, a lot of pain. She's had abdominal pain for about 9 months now. Obviously with COVID and waiting lists and things, we're only getting to see somebody next week for the camera, you know, and she's had a scan and also some tests. So I'll try not to take up too much time, obviously, but you mentioned about abdominal LAMs, and I was a bit shocked because obviously our local hospital's never seen anybody with TS before. Molly is probably the only child, you know, in this area with the whole of North Wales that we know of, that, you know, in this, that's dealt with by my hospital. So everything is kind of new, and they put the abdominal bloating down to wind, you know, lots of gas in her stomach. And obviously now, like I say, she's been tested by gynae as well because of to see if it was endometriosis or anything. That's been ruled out. So my concern now is obviously, you know, is there something going on?
Okay, so usually if you're going to, if you get symptoms due to the lymphatic problems, which is a thing that can happen in the abdomen and sometimes in the pelvis, you can usually see that quite clearly on a CT or an MRI scan. It doesn't show up very well on ultrasound. It might do, but if you have a CT or MRI, that you'll be able to, you know, the doctors will be able to see, even if they don't know much about tuberous sclerosis, they'll be able to tell that there's something that's not meant to be there. Because you only really get problems from those if they're quite obvious on the scans. So I think they should be able to tell. If, I mean, sometimes when people have lots of angiomyolipomas in different organs, they just tend, the organ just gets a little bit stretched, and that's just painful in itself sometimes, isn't it? Is your daughter on an MTOR inhibitor? Is she taking?
No.
Okay.
No, we're at the stage at the minute, I think, where the sizes are, you know, they're borderline. Yeah. So I think it's another 12 months she'll have another scan, you know, CT and whatever. So no, that was
okay. But yes, I mean, if it's going to be lymphatic disease, they'd be able to see it quite easily, I would have thought.
Okay. And would it be wise for me to ask for a scan, do you think, or because she's never been scanned, you know, the lower abdomen, it's only the upper? Okay,
probably yes. I mean, I think that would be a helpful thing to do. And if, you know, if she had an MRI scan, although they're a bit noisy and unpleasant to have, actually, there's no X-rays and things. That might be helpful.
Lovely, thank you. And the estrogen, say the gynae is wanting her to have some sort of injection or something. Should I basically mention that now? What's been said about no estrogen?
Yeah, that would be helpful. I mean, we often take queries from gynae teams and things. If they're treating endometriosis, I mean, it depends which hormone they're going to use. So things like progesterone are all right, or things that suppress estrogen, other hormones are okay. But yeah, it's just the estrogen that's problematic, really. But you know, at the LAM Centre, we often talk to people about these things. So, you know, if you want to give them, you know, our contact details, we discuss it if that were helpful. If they,
lovely.
Know, I mean, they might be on it, but
yeah. Great, thank you. Lovely, thank you.
Okay. Great, thank you, Simon and Joe. And Joe, if you want to send an email across to the TSA support line as well, we can always help with trying to get referrals and connecting up clinicians and whatnot as well. Thank you both. So we'll go to Nicola and Harriet now, and then we'll try and get through the questions that are on the chat afterwards as well. So over to you, Nicola.
Okay, thank you. It's not a very long one. My daughter Harriet, she's 40 now, but she's been diagnosed with LAMs, you know, a few years back. But mostly the problem is because she has such high learning disability, she's not able to do any of the lung function tests or anything like that. You know, if you can put something in her mouth, there's no way she's going to be able to do that. So in terms of, apart from when she's having scans, in terms of actually sort of keeping an eye on progress, in that case, is it just a case of the things that you were sort of saying about just seeing if she becomes more wheezy and all that kind of thing, and just judging it on that?
Yes, that's a really good question. And I actually meant to cover that in the talk and somehow forgot. So thanks for bringing that up. So yes, lung function tests to be reliable need quite a bit of cooperation and technique, and not everybody can do them. So the things that scans are helpful, but as I've said, we don't like to repeat them terribly often. So the things that we tend to rely on are symptoms. The other thing that's quite easy for people to do is to measure their oxygen saturation with one of the finger probes. And is your daughter able to walk okay and things? If they ask her to walk around with one of those things on, that's very helpful. If the oxygen level stays the same, that's very good. If it falls a little bit,
she can walk, but you can't get her to go sort of like at a brisk pace or anything. And she's a bit on the flick things off if they're on for very long on her fingers.
Yeah. But, so I mean, the other point to bring up is if she doesn't have very many lung cysts on the scan, then the chances of it progressing very quickly aren't very high. So, you know, maybe if there's a small number of cysts here and there, then it usually doesn't cause too many problems. So if she's 40 already and doesn't have that many and doesn't have much in the way of symptoms of breathlessness, she's probably going to do okay from the LAM point of view.
I mean, she's due another scan for lots of things in January, so her lungs will be looked at again in January. But she's just definitely more wheezy than she used to. She's got an inhaler, but she is definitely more wheezy than she was. And loud.
So has someone diagnosed asthma as well as LAM, or just?
Yes, when she was younger, mild asthma, but she didn't have to have anything for years and years. It's only been in the last few years that she's needed to have the inhaler. Yeah. Okay.
So I mean, there's a few things to think about there, but I guess she probably needs to see you probably need to get a respiratory specialist to give you a bit of an opinion, I guess. Because there might be other things that you could do.
Great, thank you both. Thank you for the question, Hilary. So we've got a few questions I'm going to try and get through here. So the first one from Alison, it's a question that I was thinking of as well, actually. Can exercise that builds up lung function, such as swimming and whatnot, help reduce the risk of developing LAM or reduce the severity of it?
So, Alison, thanks. We encourage everybody with LAM to keep fit and active. And so swimming is a really good exercise because you get a good workout. It doesn't bash up your joints and you get an all over thing. It doesn't reduce the chance of you getting LAM or the severity of it. If you have LAM, or in fact any other problem, if you are, as I say, if you're fit and active and you train your muscles and your cardiovascular system by swimming or walking or whatever it is you like doing, then your day-to-day activities will always be easier. So it's something that's very helpful to do.
Thank you, Simon. Yeah. So next one from Ian. Thank you for the question, Ian. So my daughter, age 20, has TSC2 and has one cyst and a polyphonic wheeze. Is this likely to be LAM?
Okay, that's a tricky thing. So usually if we see very few cysts and one is the lowest number you can have, really, isn't it? Those don't usually cause a problem. It's possible that there's another cause for the wheezing, and of course asthma affects 10% of the UK population, so I mean that is a possibility. Sometimes when people close their throat when they do certain things, that can make a wheezing noise. It's not usually polyphonic, as you've already highlighted. Very occasionally there's more LAM than you can see on the scan, but that's a really unusual thing. So I'd be surprised if the one cyst doesn't explain the wheezing, so I think you have to look a bit harder there.
Thank you, Simon. So a question from Hilary here. So you mentioned that you run the National LAM Centre, Simon. What patients do you see at the National Centre? So I'm going to assume, I could be wrong, but I'm going to assume that Hilary is referring to referrals and whatnot as well, or it could also be the breadth in which.
So yeah, well, we'll see anyone who wants to come, really, who we think might have that. So we're funded centrally by something called highly specialised commissioning, which allows everybody in England to come. They can be referred by their local services. The local services don't have to pay. And so anybody with LAM or suspected LAM, and we see patients with tuberous sclerosis, and so we probably see about 2/3 of the people in the UK who have sporadic LAM, and a smaller number of people with TSC LAM. So yeah, so we're there to do that.
Excellent, thank you, Simon. And that seems to be all the questions. If anyone does have any more questions for Simon, do feel free, or questions in general about LAM or TSC as a whole, do please let us know on the TSA support line, and we'll be sure to get back to you. And yeah, it's just to say thank you again to Simon for taking the time to talk this evening. It's been very, very interesting. We've covered a lot. It's been hugely helpful. I think everyone's learned a lot. Thank you to everyone who has joined as well for this live event. It's very much appreciated. The recording of the event will be shared either this week or next week, most likely, depending on how we get on. If you'd like to rewatch it or share with loved ones and whatnot. And yeah, other than that, just keep an eye out for future events. They come thick and fast, so just keep an eye out. I'm sure there'll be more that you'll be interested in as well. So yeah, so everyone, I hope you have a good night, and thank you. So goodbye.
Thanks for the invite. Bye bye.
Bye bye.